and we can, any questions you can address afterwards. So let's go through this. 68-year-old male, and I know you wanted the tetralogy of flow, so I saved it for the next lecture, but that's okay. We'll do this. This is a good one. So we'll do this. So 68-year-old male with a history of type 2 diabetes and hypertension presents with sudden onset chest pain, okay? So again, our approach, we kind of go through all these things on the right. So the regularity, is it regular or irregular? Okay, if it's irregular, is it regularly irregular or irregularly irregular? Okay, it can help us with the rhythm. That also helps us with the ways we can find the rate. Okay, the rhythm origin, where in the heart is it starting from? Ventricular axis. Okay, so what is the axis? Because it can help us with our differential diagnosis, point us to maybe different blocks or hypertrophy. Atrial conduction. So is there any atrial enlargement or defects there? AV nodal conduction. Do you see any drop beats? AV dissociation, PR interval prolongation. IV, which is intraventricular, is it prolonged or not? Then waveforms, okay, and I think eventually I'll start to put these all out here. So that's where you look at the Q waves. Are there any QS complexes? PR elevation, depression, ST elevation, depression. So a bunch of different things, okay? And then anything else? Maybe you touch on the QT interval. Is there any artifact? And then we look at R wave progression and transitional zone. Okay, and then after that, we'll make our final interpretation. So let's start with the regularity. Does this seem like a regular or irregular rhythm?
Regular.
Regular. Okay, so does everyone see that? This is a regular rhythm. Okay, does that make sense? So remember, one R wave, right, to the next. You can use any interval, and all these are the same if you measure this out, right? With your calipers or the paper, you can see that these are regular R to R intervals. So we call this a regular rhythm. Very good. So next, we'll look at the rate. Okay? And I know Raimundo is becoming a pro at the rate. Okay? 72?
Yeah.
Okay, and what do you guys feel the same? Close to that? So let's see. That is very good. And actually, the machine gave us 72. So we can kind of... So remember, when we look here, okay, when we find the rate, let's just switch over here to the... Okay, so here's our ECG. So far we said that it's regular, and we said the rate is 72 beats per minute. All right, so we said it's regular because our R to R intervals are all the same throughout. Okay, and then we know that from beginning to end, this is 10 seconds, the standard ECG. So 10 seconds times 6 is 60 seconds, which is 1 minute. Meaning that if you were to put 6 ECGs across, meaning that imagine this one here that we have in front of us is this here, okay? This represents 10 seconds, okay? Then we have another one, okay? And if we put 6 here, so 10 seconds, all of them represent 10 seconds, you can see how that can be 1 minute, okay? So what we're essentially doing is we're simplifying it to just looking at one ECG because that's all we have in front of us. Okay, so we count the complexes going across 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Okay, so you do 12, okay, times 6 because we're imagining we're pretty much making it 1 minute. So 12 times 6 is 72 beats per minute. Meaning that if we have 12 here after 10 seconds, that means we have 12 here, 12 here, 12 here, 12 here, and 12 here. So if you add those all up, you get 72. Okay, so that's kind of where that comes about. Okay, so that's one way to do it. Okay, the other way is we said this is a regular rhythm. So we can find a QRS complex that falls on one of those thick lines or close to it. And if we use this one here, okay, and maybe this one here, we count the number of thick lines between it. So 1, 2, 3, 4. Okay, and here you would do 300 divided by 4, which gives you 75. Okay, and you can see that the rate is pretty close to that. Okay, and you can only use that approach with regular rhythms. Okay, so if you want to learn only one, only learn that first one where you count these ones up here. Okay, the other thing is, where does that 300 come from? Okay, that 300 comes from is because if you count these boxes, these thick lines, and you multiplied it through all 6 of these after a minute, you'd come up with 300 thick boxes, okay? And then if you wanted a fast rhythm, okay, you can use 1,500 over the number of small boxes, okay? And that 1,500 comes because within one big box, you have 5 small boxes going across. Okay, so 300 times 5. Okay, so everyone's good with the rate there? All right, how about the rhythm origin? Where is this rhythm starting from? Sinus rhythm. Okay, and why do you say that?
Okay, so we got positive P waves in 2.
Okay, so it's positive P waves in 2, good. So let's take a look at this. That's good. I mean, 2 is a good one to have them in. All right, finally one of the main ones. So let's take a look at right here. So remember, sinus rhythm means that it's coming from the sinus node. Okay, so if we draw our let's draw our heart here first. Okay, so this is our right atrium, left atrium, right ventricle. Let me zoom in a little for you. Okay, and left ventricle. Up here we have our sinus node near our superior vena cava and our inferior vena cava, coming down through our internal pathways to our AV node. We have our His bundle. So here's our AV node. His bundle splits into a right bundle branch. Then left bundle branch then goes into a left anterior and posterior fascicle. Okay, then we have our ventricular Purkinje fibers and the cardiomyocytes. Okay, so when we say we have sinus rhythm, we're saying that it's coming and starting from up here. Okay, and you can see that the main vector is heading in this direction. Okay, so or there's also a Bachmann bundle that comes to the left side, but most of the conduction is heading in that direction. So when we take our quadrant system, okay, remember a quadrant system, this is 0 degrees, positive 90 degrees. This is plus or minus 180 degrees and negative 90 degrees. Okay, so when we take our quadrant system, what I want to do now is take our right atrium, so mainly this portion, okay, and I'm putting the right atrium here. This is only the right atrium. That does not include any of this portion. Okay, so all I'm doing is taking the right atrium, putting it there, and then we will put our sinus node where it goes, right here. And notice we said that the normal direction of that vector is in this direction. Okay, it actually goes between 0 and about positive 75 degrees. So this is normal P wave axis vector. When we look at sinus rhythm, we're pretty much looking at where are the P waves. That's the main thing we're looking at. Okay, obviously we want corresponding QRS complexes, but we first want to see those P waves. And why we do this is because we want to see them upright in certain leads, and we want to see them upright in the leads where the vector is going to. Remember, this is a depolarization vector, so whichever leads it's going to, or electrodes, you'll see upright complexes in those leads. So here's lead 1, the positive end. AVF sits down here, okay? And then we have lead 2 that sits here at positive 60 degrees, okay? At positive 120 degrees, you have lead 3, okay? And these are the positive ends of those leads, all right? And then we have AVR here, okay? And then in the horizontal plane, we also have some leads here where we have V4, V5, and V6, okay? So our vector is heading in this direction towards that, meaning that these leads here should have positive upright complexes. Okay, it's going away from AVR, so we should see negative P waves in that lead. All right, so far so good. All right, so if we look at our EKG here, right, we have our patient here. We should see upright complexes in, we said, lead 1. Okay, and you can see them there. Okay, they're small, but they're even more evident in lead 2. All right, so we said 1, we said 2. Okay, you can also see them in AVF. So here's AVF. They don't always have to be there. They're not always in lead 3 because look where lead 3 sits, right? But you can sometimes see them there, and they're there in this case, okay? Where else? Well, we said in the precordial leads, V4 to V6. So here they are here. Again, a little hard to make out in that. V5, a little more evident, and then V6, okay? And then in AVR, they should be negative. So here's AVRs, negative P waves, okay? So a little hard to see because those are smaller complexes, but they're there, okay? And then the other things is we want the P waves to have similar morphology. So I'll kind of switch back here so we can look at this. So the P wave morphology, if you look at lead 2 in the rhythm strip, look all the way through and you want to see that the P waves look the same. That's what we mean by morphology, okay? So they all have a similar shape to them, which is one of the criteria, Okay, we don't want a wandering atrial pacemaker or other sort of atrial arrhythmia going on. So this is that, and then we have P waves that are followed by QRS complexes. Okay, so this is in fact sinus rhythm. Okay, so very good. All right, does that make sense?
Can I see that?
Yeah, sure. Oh yeah.
That this just for this picture alone, the 75, that is strictly for P waves.
P waves only. So remember, everything has an axis. The P wave has an axis. The QRS complex has an axis. The T wave, the ST segment, right? They all have their own axis. All right, and those are pretty much vectors, and that's why we see elevation, right? Because that's a vector that we're seeing produced on the ECG. So ST elevation is a vector that's coming about from the ischemic region. All right? Okay. You're welcome. All right, so sinus, and then what is our axis here? We have normal axis, leftward axis, rightward axis.
Left.
Left axis? Okay, why do you say left axis?
Lead 1 is positive and AVF is negative. But then I also look at lead 2 now.
Okay, very good.
When that's negative, then I'm pretty sure.
Truly sure. Good. Okay, so let's see why that's the case, just so we're all on the same page. Okay, so when we're looking here now at axis, okay, so we can use just another piece of clean sheet here. So when we're looking at axis, again, we'll draw our quadrant system, 0 degrees, positive 90 degrees, plus or minus 180 degrees, and negative 90 degrees. Okay? Now, when we're looking here, and we're looking at ventricular axis, so we're going to focus on those QRS complexes, all right, representing ventricular depolarization. So when we look here, we know that the normal axis in adults lies between negative 30 and about a positive 100 or 105, around 110 degrees. So meaning that, remember, the P wave was 0 to 75. This is normal in adults. Okay, remember, in children, they have more of a right axis shift, so they'd be more in this region, okay, because the right ventricle is the dominant portion in utero towards the end of gestation up until about 1 week of life, because then the lung starts to take over and the left ventricle becomes the most dominant. And as we get older, right, the left ventricle has to go push against the body, so it becomes even bigger, and that's why we often see these leftward shifts as people get older. Hypertension, aortic stenosis, things that increase that pressure in the left ventricular work will cause it to shift leftwards. Remember, the left ventricle sits mostly posterior. All right, so right axis shift, this is left axis shift, and this is more pathologic, we call it. If it's in this region, we call it physiologic left axis deviation, and this is what we call extreme axis deviation. You may hear it as no man's land, or also a superior right axis, you may see it as, or northwest axis, because we're going north and it's west, so this is northwest. Okay, we see it in VTAC, that's a common thing. All right, so when we look here, we know that lead 1 sits here, okay? Lead AVF sits here. So those are the ones that I want you to start looking at first as you're learning ECG. So when we look at lead 1 is here, and they're hard to make out, but these are clearly positive, okay? You can pretty much see a deflection that looks like this, okay? And what I'm comparing is the deflection downward, this, to this R wave, okay? The Q to R wave. And you can see that this is mostly positive, so I just call this positive, and we're going towards the positive end of lead 1. Okay, so positive towards that direction. Okay, and then I look at AVF, and AVF is right here, and when we compare it, we can see that this is mostly negative. We really don't have much of a positive deflection, so negative, here's the positive end of AVF, so we go away from it in the negative direction to this direction. That leaves us in this region, okay? So this over here, which we said is either physiologic or pathologic. Now, if this is a 10-year-old child or adolescent, right, and then I may think this is abnormal. But when I'm looking at a male with 68, he has hypertension, right? Type 2 diabetes, certainly a cardiovascular risk factor, okay? So we don't really think of it. Now we have to find out, is it in that pathologic range or is it physiologic? And that's where Raimundo was mentioning we use lead 2. Okay, lead 2 comes here, as we mentioned, at positive 60 degrees. So this is where lead 2 is. Okay, so lead 2, and it also sits here. And we look at it. If it's mostly positive, so again, 60 is here at lead 2. Perpendicular to lead 2, which is convenient, is this line here. Okay, which is that negative 30 degrees. Okay, so meaning that if it's positive in lead 2, we head towards it, okay, and we'll be in this region here. If it's negative, we'll go in this direction and we'll be in this pathologic region. Okay? So we're trying to figure out, are we in this region here or this region there? Okay? So if we look at lead 2 is mostly negative. So we're going away from the positive end in this direction, which puts us in this region here. Okay, and that's what we call a pathological left axis deviation. Okay, so we do certainly have left axis deviation here. Okay, does that make sense? Okay, I know that was people were having trouble with axis at our session, and you can see here it is negative 76 degrees. Okay, does that make sense? Okay, so I don't know. There was a thing that despite it, try to simplify it as much as I can. But sometimes I think vectors get people caught up, which is fine. And I've been there too. So sometimes keep going over this will help if you don't get it this time. So next we look at atrial conduction. This is kind of where we're looking at those P waves, okay? And in the P waves, right, we're looking for any atrial abnormalities. Is there any right or left atrial enlargement that may be going on here? Okay, so we've looked at the regularity, rate, rhythm, origin, and axis. So atrial conduction, okay, these P waves here, do they appear abnormal to you? Okay, so no, we don't see any peaking of them, which may suggest maybe a right atrial involvement, right? The best leads to look at are lead 2 and V1, all right? And in this case, we don't see any right or left atrial enlargement, so it's in this case normal. Next, we look at AV nodal conduction, right? Here we're looking at the PR interval. Is it prolonged or not? Any dropped beats? Is there any AV dissociation going on? And in this case, we already mentioned that there's no AV dissociation. We said that there's sinus rhythm at a normal rate. And in fact, this is normal conduction. Okay, so the PR interval is almost at that upper limit. Remember, in adults, 120 to 200 milliseconds, or that 3 to 5 small boxes, is normal. And you can see here that it's just kind of coming within that normal limit. Okay, so from here, just meeting at 194 milliseconds, so that upper limit, but still within normal limits. No drop beats, no accessory AV pathway, which we may see in Wolff-Parkinson-White, WPW, or Longenong-Levine, LGL syndrome. Okay, and no AV dissociation. All right. How about IV conduction? This is where we're looking, is the QRS interval prolonged or not? In this case, we said we have narrow QRS complexes. Okay. We said we have an origin at the sinus node, no escape rhythm. So this is normal QRS or duration and interval at 86 milliseconds. In adults, remember, 70 to 110 milliseconds is normal. Once you hit that 120 milliseconds or 3 small boxes, it starts thinking prolong. Okay. So that's what we have so far. Now, how about waveforms? Are there any abnormalities you note in the waveforms here? Are there abnormal Q waves or ST segment changes that you notice?
Elevation.
Where do you see that?
2, 3, 4, and 5.
Very good. So V2 all the way up to V5. Very good. All right. So we see ST elevation. How about abnormal Q waves? Do you see them anywhere? So maybe in those same leads, right? Okay, and those are ischemic. Remember, when we looked at the progression, that's kind of what we see in the subacute phase of those Q waves, right, as the ST segment's starting to come down during ischemia. Now, we also have in 2-3 AVF Q waves that are there, right, deep Q waves. So what I mentioned here is that we have deep Q waves in V2 through V5, as well as 2-3 and AVF, those inferior leads. We also have ST elevation in V2 through V5, as you mentioned, and there's also non-specific T-wave abnormalities in 1 AVL, V6, and 3. And when we talk about these non-specific T-wave abnormalities, they really have no significance. Okay, but they're there because they're flat. So if you look at 3, you see flat, and it may because these may be a result of chronic ischemic changes. Okay, so the patient had an infarct in that region, and they just haven't reverted to normal yet. Okay. Did everyone see those changes? Next, we said, is there anything else? And I think there was one thing here I wanted to mention. Is a prolonged QTC interval, 453. Now, is this clinically significant? Oftentimes not. It's our male patient. So not until we get around 500 milliseconds are we getting too concerned of what medications we're giving that we can precipitate out an arrhythmia. But in this case, 453, it's okay, but technically prolonged. So I put that there. All right. Now, R-wave progression. Okay, this is again these last two things in the precordial leads, R wave progression. As we go from the right side to the left side of the precordium, the R wave should increase in amplitude, and you can certainly see that we don't have that here. All right, 2, 3, 4, and even 5, we have those Q waves that are pretty much predominating. Okay, so there's something going on, and we call that poor R wave progression, which may be something that's going on in that anteroseptal region. Okay, all right, and then transitional zone. That's again in the precordial leads where we're looking from complexes going from mostly negative to positive. And you can see V1 mostly negative, V2 the same thing, deep Q waves, okay? And these are Q waves, so they're abnormal. And then maybe you see a shift here in V5, okay? Again, this is in the setting of ischemia, maybe the patient with sudden onset chest pain. Okay, we have an idea of what's going on. So we call this a late transition because remember, normal transitions between V3 and V4. This is coming late and afterwards, and we call that a clockwise rotation or late transition. Okay, so clockwise or late transition here. Okay, so what's our final interpretation as we put this together? All right, so we said we have a regular rhythm, the rate at 72, sinus origin, a left axis shift. Okay, normal atrial AV and IV conduction, and then we see these waveform abnormalities, okay? Is there anything else that you notice? Okay, so just along that prolonged QTC. So overall, our final interpretation here is a normal sinus rhythm. We have an anterior infarct, likely subacute, okay, because you have those ST elevation changes as well as the Q waves that are now seen in those anteroseptal leads, and you have a prior inferior infarct that's going on, it's chronic, with a prolonged QTC interval and nonspecific T-wave abnormalities, okay? Now, when we compare it to a previous ECG, as we always do, to make sure there's no new changes that we're missing, right? Okay, because normal changes on here can actually be ischemic, such as in